Neck pain and migraine are so closely intertwined and yet so confusing. Many people in our Yoga for Migraine Facebook group asked, is my neck pain causing my migraine or is my migraine causing my neck pain? And what can actually help? Hi, I'm Adriane Dellorco, the creator of Yoga for Migraine and Beyond Migraine Coaching. And today I'm really excited to bring clarity to this conversation. Is neck pain causing your migraine? And we'll have a wonderful leader in the headache world explain. Annika Ehrlich is a family nurse practitioner and doctor of nursing practice, a certified neuroscience nurse with an additional qualification in headache from the National Headache Foundation. She cares for patients at UCSF Headache Center and is an assistant clinical professor at the UCSF School of Nursing. She's a clinician, but also a national leader in headache advocacy and education. And she's the board president of the Alliance for Headache Disorder Advocacy, the president of the Headache Alliance, and more. Annika works at the intersection of science, patient care, and advocacy, and has a deep knowledge and understanding of how complex and individualized migraine is. So our conversation on neck pain and migraine is guided by questions that were submitted. So we'll go over what the difference is between migraine and maybe other headache disorders that have neck pain, and what kinds of at-home strategies can actually help. So Annika, welcome again. Thank you so much for being here and helping us to better understand the connection between our neck and migraine.
Thank you so much, Adriane. I will do my best. It's confusing, I think, for all of us. So I'm hoping to lend some clarity, but also I think one thing I definitely want to make sure folks understand is that sometimes there are a lot of things overlapping here, and everyone is different. But yeah, hoping to clarify some items if I can.
Sounds good.
Mm-hmm.
Well, let's start with what are some of those connections between
Mm-hmm.
neck pain and migraine? Is there commonality? Is that a common symptom for both?
Yeah.
Tell us what the connection is.
Neck pain it's incredibly common in migraine. It's actually really interesting, and I think it's really important for people to understand how common it is. Some studies show anywhere from, say, 70 to up to even almost 90% of patients who have migraine have neck pain as an associated symptom. It's sometimes, more common than some of what we think of, and what are diagnostically the criteria. So like nausea, for example, is one of these, qualifying criteria for a diagnosis of migraine. Neck pain's not included on the diagnostic criteria, but it's more common in patients who have migraine than nausea. So that's pretty, I think it's always because it's so common and patients are like, what is going on with my neck? The nerves that, innervate your neck, so the back of your head and your neck, and the nerves that innervate the front of your face and head, they all connect deep in the brain in this area called the brainstem. So it's kind of this hub where everything is connecting, and then there's like feedback loop mechanisms and signals that are sending back and forth. And there's oftentimes this, so when something is signaling back here, we can see it be referred or then signal up to the front of the face. And so it's all very much connected. And when something kind of starts back here, it can signal deeper and then kind of promote signals or pain signals somewhere else in the head, neck, and face. So they're very, very much connected and super common in migraine.
Okay. So would you say that it's bidirectional, or is it more typical that the neck pain is a symptom of the migraine, or could it be the other way as well?
So it can be both. So some people, we're learning more and more about what we call the prodrome phase. Sometimes people call it premonitory phases in migraine, and how common some of these symptoms are before you actually get the headache. So a lot of people might sort of recognize this in themselves where they, in the hours leading up to and before they develop a headache, they might have some symptoms. There was a study that was done just recently in this past couple of years that saw patients being able to correctly predict these premonitory symptoms, or what we call prodrome symptoms, neck pain was one of the most common symptoms that patients were able to say, this is the, like, I'm getting this symptom and I know that after this, in a couple of hours, I'm going to develop the headache. And what they did with this, and this was a prodrome symptom looking at one of our GPANT medications, so ubrogepant, for example. So this is the data that we have to support that if we, researchers use this medication, ubrogepant, in patients who could almost always reliably or always reliably predict these headaches after they got, say, neck pain, if that was their most prominent symptom before they had the headache. And they were more able to then prevent that headache from occurring when they took the ubrogepant at that time. We don't have data for other types of medications, but we always, this is something that we always stress to patients, to take your medications early. I think this type of data shows us that the migraine cascade is starting to happen. The earlier we cut it off and kind of prevent those feedback mechanisms and loops and all of these things from kind of communicating, and the inflammation cascade, everything from happening, the earlier we can stop that from happening, then we can maybe even prevent the headache from happening. And it's very closely linked, clearly.
Yeah, I think that's such a valuable skill that I also coach the clients I work with, is taking your meds early and tuning into those prodrome symptoms is so valuable. And just for you guys to hear from a headache specialist, like even taking it before the head pain has started with neck pain, like that can be helpful with, the data shows for certain acute meds.
Yeah.
So
and it's tricky. I think it's so hard sometimes to predict, but continuing, I think, to be your own scientist a little bit, and observer as to, what we don't want to, I think we sometimes, keeping a diary and tracking all the symptoms, it can be a lot for some people. So if that's too much, like, totally understood. But if this is a pattern that you're noticing,
sure.
I think it's worth listening to and realizing, like, aha, this might be part of my whole migraine picture.
Yeah, absolutely. So there are seems like there's a few different headache disorders that have neck pain, migraine being one of them.
Mhm.
We've also heard about cervicogenic headache, occipital neuralgia. How would you diagnose what's what? How does a person maybe know what they're dealing with, or could they
Right.
have a combination of some of these things?
Yeah, I think we want, as clinicians, we first, you want to make sure that you're getting the right diagnosis. So that's always step number one. We want to make sure we're not missing anything. And of course, a lot of people who have really significant neck pain, they want to make sure there's nothing wrong going on. And there are different diagnoses and headache diagnoses that have to do with the head and neck and the kind of the back of the head. So of course, there is migraine, which is really, really common, 8 to 12% of the population, sometimes more, depending on your stage of life and if you're a female, or something like that. And then the neck pain is really common and goes along with that. Neck pain and migraine, I think about, so we always want to ask the patients for a really good headache history. So coming in and being able to really describe and write down, so keeping a diary, noticing, if you do have neck pain, when does that neck pain occur? Is it triggered by anything in particular? Does it seem to happen either right before the headache comes on, or the hours before the headache comes on, or during the headache? Or is it something that's happening all the time, no matter what, not in relation to your headache? Is it happening when your neck is in a certain position, for example? And then you always want to tell your clinicians whether there's, any sort of numbness, tingling, pain radiating down your arm, weakness. You can't grip something. Like, those are warning signs that this is not migraine, but there might be something else going on deeper that we need to look more closely at. Certainly, sometimes there are strange sensations and things that can go along with migraine. But if someone is having, issues with sensation, if they're having numbness or tingling or weakness, you need to let someone know about that, because there could be something structurally going on. So we always ask about that. We always ask about, did you ever have a head injury, for example? So this is a really important for your headache history, because if someone, is having neck pain and it seems like it's just associated with the migraine, we might say, okay, it's probably, we're going along those lines. But if someone has a history of, say, a sports injury or concussion, if they've had a car accident or multiple car accidents or types of head injuries. This is really important information for us to make sure we're not missing anything. If you have other medical history that might put you at higher risk for having neck issues or instability, like Ehlers-Danlos, for example, these are things that we need to know about. Or, if you're concerned and you want to ask your clinician about it, that's a good thing to ask about to make sure we're not missing anything. And then we'll look on the physical exam. So before we even get to the diagnosis, we do a full history. We go over your medical history, your family history, your social history. What do you do for a living? Are you at a computer all day long, or is there something that you do for work that causes your neck to be in a certain posture? Like I particularly think of patients who are, dentists, dental hygienists, and the way that they have to kind of crane their neck, and that can certainly cause neck injury over time. And then we would do a physical exam. And part of the physical exam is really looking at range of motion and making sure the patient has full range of motion in their neck. They're not having pain when they're moving their neck around. And then we might do some maneuvers to test whether there's compression of the discs and whether that elicits any type of pain. And we also feel around and kind of palpate, so touch the head and neck and feel around the back of the head. Especially there's this area around the back of the head where the greater occipital nerve is running. And oftentimes patients might have some tenderness there, and that can give us clues to diagnostics. And of course, we're palpating the muscles in the neck and shoulders and the back of the neck and the physical structures there. And then we have these different categories. So there's migraine, which can certainly have neck pain associated with it, as we discussed. Cervicogenic headache, this is a specific diagnosis. And we think of it as a secondary headache diagnosis. So migraine is primary headache diagnosis, where that is the disorder. The cervicogenic headache is a headache that is deriving from something going on in the cervical spine. So this is the neck area, either in the bone, the discs in the neck, the tissue. So it can kind of cover a lot, but it's accompanied by neck pain. And there has to be evidence that this is causing, kind of associated with this. And if we maybe relieve whatever is going on there, then that will relieve the headache. And that there is some, issue with, range of motion or something going on that provokes the pain with neck maneuvers. And also maybe there's some relief when we do procedures that might, be a nerve block or something like that, where we use anesthesia to block the nerve pathways, and that helps the patient. So, cervicogenic headache on its own, it doesn't affect that large of a portion of the population, maybe 0.4 to 4%. But in patients who have chronic headache disorders, it's more common. And so this is where this question comes up: is it the chicken or the egg? Kind of which comes first? And we think of these other secondary headache disorders, which can overlap with, say, migraine, as kind of these noisy neighbors that both can sort of do their own thing and cause pain or discomfort. But then because it's sending these pain signals, then it can be maybe triggering the migraine. And so we need to kind of be treating the whole component and the whole patient with these different things going on.
Wow. Yeah. So people can be dealing with more than one of these, and it can be hard to figure out what's what.
Mm-hmm. And then we have occipital neuralgia, neuralgia is really it's a word for nerve pain. So neuralgia is a little bit different. Migraine is characterized by moderate to severe throbbing pain that can last hours if untreated, up to days sometimes, right? And it's associated by this light sensitivity, and there's all these things that go along with it. Neuralgia, and this type of neuralgic pain, like occipital neuralgia, it could be on one side. So the occipital nerves run in the back of the head, and it comes with this all of a sudden sharp shooting, stabbing pain. And we treat this with, nerve pain medications and also procedures. So oftentimes doing nerve blocks in those areas. And this is an in-office procedure, either with or without ultrasound, where you inject anesthetic around those areas. And usually it can be tender to the touch, those areas. That's where we get typically good relief with those types of treatments. So that's, that's a little bit different in terms of, but can certainly be interpreted as maybe neck pain or back of the
Mhm.
head pain.
Yeah, well, thank you for outlining what's what, how someone could get diagnosed, what to look for. In terms of helping with neck pain, what are some things that we can do? Is it, maybe we'll take migraine, for example. Is it a matter of treating your migraine, or is there something that we can do to relax the neck or strengthen the neck? What are some
Yeah.
options?
I think treating, if we have ruled out, and everyone is a little bit different, but if you've ruled out that there's not anything structurally going on, and that, there's not concern for that,
Mhm.
and not everybody, if there's no traumatic history, if there's no suspicion that there's something else going on, and it's really kind of this neck pain that comes along with one's migraine attacks or before the migraine attack, we've treated as part of the whole migraine picture typically.
Mhm.
So, really focusing on acute treatments, whether that be medications or not, so certainly acute treatments also include things like ice or heat or neuromodulation, included, and then medications for sure. So hope, again, it's that treating as early as possible with whatever tools you have in your toolkit when that attack comes on and you feel like, uh-oh, this is starting now. Or if you're getting, frequent symptoms that you want to get on top of things and talk to your clinician, talk to your headache specialist, your neurologist, your primary care, that maybe some type of prevention is needed. And that hopefully overall will reduce the migraine symptoms. So we think of these migraine symptoms as all linked together, and that should help. And if it's not, then you may want to think and talk to your clinician about some more targeted therapies and for what, if there's something else going on, and do a little bit of a deeper dive on the neck pain specifically. But all of these things can be helpful.
Yeah, so it sounds like trying to get the migraine under control will help with the neck pain. Just some questions that we had from people in our group. Chelsea asked, "Why does the neck stiffen up and tighten during an attack?" And yeah, I personally get more trigger points and knots in my neck the worse my migraine is. Is there a
Mm-hmm.
connection there?
I mean, there definitely is a connection in terms of the muscular tension and that being a trigger, I think, in for the nerves and just that overall sort of heightened sensitivity in these areas.
Mhm.
We know that things like tension type headache often kind of is characterized by this muscular sort of tension, and that's even more common than migraine. And whether that's something that's going on then is triggering sort of migraine symptoms, but definitely working on these issues, whether it be, we know that working on relaxation overall, sometimes through direct massage or trigger point injections. We don't have the best evidence for and literature to support these sort of trigger point injections per se for migraine, but we
Mhm.
know that a lot of patients do benefit from them. And if they are having this sort of chronic neck pain or neck pain that's frequently, neck pain and migraine symptoms frequently triggered by these trigger points or these areas of kind of tight muscles that are, we really think of the muscle cells as being and the tissue being tightly held together, and then trigger points or massage, those kinds of things help these areas relax.
Mhm.
That can be helpful for a lot of patients, and even just gentle massage in these areas sometimes can be helpful. And we'll talk about, I think, some other
Yeah,
things that you could think about.
yeah, we had some questions if, at home neck massagers are helpful or vagus nerve stimulators, chiropractors. Is there any data on any of these other things?
Yeah, we don't really have that much great data on massage
Mhm.
for migraine, but that's not to say it's not really helpful for a lot of
Yeah.
patients. And massage, whether it's with a therapeutic masseuse or if it's something that you do at home, gently head and neck massage. You might want to think about combining that with some aromatherapy. There's not the strongest data, but there is some really interesting, kind of thoughts around certain types of aromatherapy and how that can be therapeutic in pain disorders. And so things, like Tiger Balm can be helpful for some patients in terms of that gentle massage in these different areas. So if there's areas of muscle tension, lavender oil, I mean, I think that could be a really nice adjunct to use for massage. And again, this is only if you're able to tolerate it from kind of an aroma standpoint. Some people are really triggered by scents. So everyone's a little bit different, but some of these things can be therapeutic. Warm packs can be nice in helping to get those muscles to relax. And then maybe alternating with, either ice. So sometimes people find ice better than heat, using an ice pack on your head or one of the cold caps, just being really mindful to have things not too cold and not too hot, so you don't want to injure yourself. The massage devices, I always get a little nervous with these massage guns because they can be kind of intense, and we want to be really careful around the neck structure. So I don't want anybody to injure themselves, or some of the vessels in your neck are very delicate, and the bones in your neck are delicate, and I don't want anybody to injure those or injure their discs. But if you kind of stick to the larger muscles in your back per se, then I think it's okay. But being nice and gentle is a good idea.
It's a good guidance there. We had some questions from Claude and Karen about headaches associated with age-related changes in the neck, so arthritis. And I don't know if that is related to cervicogenic headache or if that's another
No, I think so that arthritis in the neck absolutely could be a cause of cervicogenic headache. And so, age-related arthritis, that kind of a thing definitely sometimes needs multimodal treatment with other specialists sometimes. We want to make sure, like I was saying at the beginning, that you're not having any other symptoms related to that. So if there is some sort of degeneration, the concern would be from a clinical standpoint, any sort of compression of the nerves or discs. So anything, if you're having it getting worse or you're having any trouble with function, sensation, moving, even just your, kind of leg stability, arm stability, this is something that requires more urgent evaluation and making sure that there's imaging, that there's not something serious going on because of, say, an arthritis condition or some other degenerative condition in the neck. If that's the case, if that's not the case, and things, there's just maybe an aging process or arthritis process that's going on, I think we want to be really, working with physical therapy on exercise programs, on how to strengthen the neck with physical therapy. Sometimes occupational therapy is even helpful with that. And then maybe working with specialty practices like, there's doctors of osteopathic medicine that are very good in terms of the physical musculoskeletal components. Physiatrists can be very helpful with that as well. And thinking about activities where you're keeping moving, but you're not harming your neck. So things that can be, super jarring, like running, or sometimes also cycling. When people have their neck in this certain position and they're kind of like this, that might not be the best exercise. We love swimming for migraine in general because it can be so gentle, and also sometimes the cool water is really nice. But for people who have neck issues, that turning their head like this can be a little bit of an issue. So nice, slow, gentle movement with the neck. I've had patients who they use a scuba, a scuba mask where they can keep their head still in the water so that they're not turning it side to side. That's an amazing solution if you're able to tolerate that kind of pressure on your face and you want to swim, because I don't want to keep people from doing what they love doing, but we also don't want to exacerbate these neck issues.
And in terms of, things you said to look out for, if there's tingling, if there's something else going on outside of maybe the head and neck area, those are good indications you want to get checked out.
Oh, yeah.
Okay. We had a lot of questions about pillows and if the way that we sleep, even our sleep position, can that exacerbate our neck and our migraine? Any recommendations or thoughts?
I know. I think, and this is something, I think if your neck is to the point where you're waking up with a migraine or headache every morning, and it's that significant, I want you to go see a clinician and talk to them about what's going on, because there could be, it could be just position, but maybe there's something deeper going on that's causing, if you're sleeping in a certain position, it's exacerbating it. There are things that we sometimes like to do and talk to patients about in terms of, having their head in a little bit of traction, maybe not sleeping all night with your head in traction, but sometimes just even a rolled up towel under the neck to kind of pull up a little bit, or making sure that you're not crunched like this, in sleep. They have these pillows that are, more adjusted and softer that can, hold and keep your neck in a stable position, without either extending or flexing it too much. So there's certainly those. I don't have any ones in
Sure.
particular that I recommend, but I would want someone to get checked out more if it is, because there are other things that can cause you to wake up with a headache or neck pain every morning.
Mm-hmm.
And we want to look a little bit deeper into that.
Yeah, got it.
Mhm.
Uh, so I've heard different people discuss neck pain in different ways when it comes to migraines. Some people advocate more like we want to relax the neck muscles and do more stretching. Others say, no, we need to strengthen those muscles because those are often weak in people for migraine. Do you have any
Mhm.
sense of what's what there?
Yeah, I mean, I think, again, it can vary a lot per patient.
Sure.
Sometimes doing too much is not always great because we're kind of just promoting this sort of movement and strain um, and tension. But there are some cases where I definitely think next, so we want people to be active and have strong, upper kind of shoulder back muscles in order to hold themselves up. What we do see sometimes, uh, that can really trigger or worsen migraine in patients is when they have this sort of forward posture. So, your head should be kind of up, nice and stable and aligned with the shoulder here. And if it's like this, or things are starting to round here, or you're going like this, and there's this forward posture, that's when we really can see physical therapy and working on this, straightening or at least strengthening a lot of these muscles here in the head and neck, because that might be a significant, contributor
Mhm.
to head and neck pain. So we want to work on strengthening that, and a good physical therapist can really help to do that. And then, sometimes we also need to involve other types of specialists, but that's definitely something we see commonly.
Yeah. And I know for myself and many people with migraine, our neck can be just more sensitive. And so even doing things that, are more strength building, sometimes we can be a little more easily triggered. And I think just
Yeah.
going really slow and steady, but consistent in trying to build up muscle, it's all great things to do in the long run, but we do need to take it slow and easy with our necks, like you said.
Yeah.
Well, Annika, thank you so much for helping to make sense of this very complex relationship between our neck and our migraine and head pain. It really highlights that migraine isn't just about the head. It affects our whole body often, our nervous system, our muscles, how we move. And if you are looking for help in your migraine, I love to support you in taking more of a whole person approach. In my Beyond Migraine coaching program, we integrate migraine education, nervous system regulation, gentle movement like yoga for migraine, and pain reprocessing tools to help you feel more confident in your body, less afraid to move, less afraid of your symptoms, alongside your provider's care. So I'll put the link for Beyond Migraine in the show notes. And thank you, Annika, again for sharing your expertise, and to everyone who submitted questions. We'll see you next
Thank
time.
you.